Can you hear me?
Yeah, it keeps coming in and out.
Do we have any cases?
We have one submitted. The presenter isn't here, so we were just going to wait until the end and present that for them if we had time after questions and everything.
Okay.
Okay, because then if we don't have time, then they can come to the next one and present themselves, but we'll definitely use it if we need to.
Okay.
All right. Do you want me to share the didactic now?
Sure.
Great.
It just went away.
There we go.
There it is. Okay. So I was asked actually to go over nutritional management. The only issue with that is I'm not a nutritionist. So this might be actually pretty generic for everybody. And we were asked to discuss a little bit about the holidays and things to consider through the holidays. So next slide. Just awareness, so you guys know next month, even though this month is, I'm already at Christmas. This month is Diabetes Awareness Month. If you actually go on the ADA and some different websites, you'll see some extra information actually up this right now for diabetes. Next slide. So I wanted to try to keep a little bit formal as far as what does the ADA say, and they had a consensus report that was put out in April of 2019. So you guys can actually read it, but individualizing nutrition therapy for adults, and they're talking about diabetes and pre-diabetes, can help cost effectiveness, the quality of diabetes care, medical management is definitely altered with it, and that it's important for everyone in the healthcare team to consider nutrition, and that it's a key part of your diabetes care. So we have people that have changed their diet, lost weight, and literally lowered their A1Cs by 2 and 3%. So nutritional counseling works towards improving and maintaining glycemic controls. As I said, weight loss goals, and also cardiovascular risk factors such as weight loss helping with blood pressure, and weight loss helping with cholesterol levels and that type of thing. So individual treatment plans are also encouraged. ADA emphasizes that medical nutrition therapy is fundamental for overall diabetic plans, and the need for medical nutrition therapy should be reassessed frequently by providers across the patient's lifespan. I think that's one of the hardest things even here that we have trouble is trying to get patients back into medical nutrition therapy. They know it all and they don't. And that's, I think, the biggest thing, that you have to somehow work through that barrier and try to get these patients back in, because they went to one therapy session. Honestly, that's the thing. They think they're good. As times have changed, not that nutrition actually changes, but their way to reassess themselves has changed because their activity levels have changed. As people age, they don't like protein. They don't like to chew meats. So that aspect also changes. So they always say that their diet didn't change, but it has, because they don't eat meats the way they used to. Elderly don't like to drink water, and water will lower A1Cs and help bridge sugars. And so making sure, those types of aspects as they go through their lifespan are addressed, I think is really important. And the biggest barrier is getting patients back in, because they believe they know it all because they went one time, and that honestly isn't the case. And there's also a lot of apps out there. I tend to use MyFitnessPal because it's free. It also has portion servings. You click on an extra button and it will give you carbs, calories, fat intake. So getting them some extra resources at their fingertips will help with their overall nutritional plan. Next slide. So this is in the ADA under lifestyle management, the standards of care, and you can see that it's pretty big there. So I'm not going to read it, but the highlighted is that there is not an ideal percent of calories from carbohydrates or protein and fat for all people of diabetes. So it really has to be individualized. So patients want to talk about that, but that's where they have to go to medical nutrition therapy so that they can get that individual plan. And then also working with patients for what they like, you know, because they like potatoes. They're never going to give it up solely just because you say so. So what can you do to substitute or decrease the portions? You know, what time of day can they have potatoes versus, you know, in the morning versus late at night and stuff like that. So a variety of eating patterns, are acceptable for the management of diabetes, and a referral to a registered dietitian or a registered dietitian nutritionalist is essential to the overall nutritional status. And that's why I said, I'm not a dietitian, I'm not a nutrition person, but right there it says that that's where they should be going. So kind of forcing the arm and making them attend some type of nutritional class throughout their lifespan is necessary. I get asked all the time what diets, because there's always something out there. For people that just want weight loss, I always tell them to experience, lots of different diets, figure out which one works for you, which one you can sustain. But for my diabetics, I tend to push the Mediterranean diet for them. And then most of them have some type of hypertension. So then I discuss the DASH diet as well. So those are also in the ADA as recommendations. So I would utilize that as your kind of go-to until they can get to a nutritional person to individualize it for themselves. Next slide. So for the holidays and things that you can actually do, this is just me using Google World, so anyone can do this. Cauliflower pizza, it's a low-carb alternative to traditional pizza. They are in some pizza shops and stuff like that, so let your patients know that that's even available for them. Sometimes people don't think about sauces, but there's a lot of sugar in pizza sauces, so even if they're eating the bread, if they could make their own pizza and modify the sauces so that they're not getting a whole lot of sugar added through that, and then choosing more protein types of toppings and the veggies and stuff. Swapping out pasta also for the zucchini and using types of ribbons and stuff like that. 4.8 grams of net carbs per serving. That's like insanely low compared to your pastas. People always ask about whole wheat pasta and that type of thing, and they really just need to look at the boxes. Of course, whole wheat is better, but it's a lot of times not different in total carbohydrates. So iceberg lettuce, I always tell my patients take off the top part of the bun. They shouldn't really ever eat a hamburger with top and bottom. So that's something they can do and use the lettuce as their top portion of that. Kale chips instead of your potato chips. They're super easy to make. And then basically a bag of kale on your frying or on your baking dish is all you need to do with some olive oil and salt, and that's excellent. The other thing that I don't have up there is cauliflower rice. It's chopped up in frozen section, and it really does, it looks like rice, but it doesn't obviously taste like rice. But it's a good substitute for people that are rice eaters to try to have some cauliflower rice, and it's just chopped up nice and fine like rice would be. Next slide. All right. For Thanksgiving, this was basically substitutes that you can have. I pulled this off of the internet, and I forgot which site it was, but just giving them ideas like the cauliflower, again, that's been used a lot for substitutions for obviously rice and potatoes. Green beans, most of the time that's not the problem. It's all the saucy stuff that they put on top of it. Hemp pilaf. I've never had it, but it really has a lot less net carbs. So you can ask them to skip that and try hemp pilaf. Then cauliflower mac and cheese, you can see that that's down to only 6 grams per serving. Cranberry sauce, talk about that with people. Sometimes making your own is better because then you can use the salt or sugar substitutes and not using, directly from the can will lower your carbohydrates. So pumpkin pie, pecan crust. We actually have, seeing that you guys can't see us right now, but we have a flyer out that's by American Association of Diabetes Educators. If you actually go on it, Cherie, tell them where you got it.
So there's an AADE website, and it's for diabetic educators. And you can go out there, and it has a lot of tools for just kind of handouts, things that you can give your patients. But I found one that's for seasonal. It kind of focuses on holidays with a big meal and things like that. And it not only talks about foods, but also drinks, like your beer, your wine, your alcohol. And it talks about how to safely have those over the holidays. It doesn't really cut out completely, desserts. It talks about how you need just to plan for them. So you can't eat your macaroni and cheese and mashed potatoes and dessert. But if you, focus on your turkey and vegetables during your meal, then you can save room for dessert. So it really talks about overeating and things like that. And at the end, it has a cheesy little contract that you can put on your refrigerator, and it says that that I make a promise to myself to make healthy choices during the holiday season, will balance my food intake, limit my sweets and desserts, and avoid grazing between meals. So it's just kind of a reminder that they put on their fridge, so that people aren't also trying to, I'll try this. I'm really trying to watch over the holidays because it is just one day and it is a meal. So they don't need to completely blow everything for it.
Next slide. This is more about a low carb things, like we said, as far as diets and stuff like that. So patients that are very active in their meal planning and stuff like that, they certainly could try a different type of stuffing. So giving them and explaining to them ideas of, a pumpkin bread and sausage and feta stuffing. Talked about the potatoes and using something such as turnips instead, and the cauliflower instead, and the rutabaga instead. So, there are substitutes out there. I think the biggest issue is, patients' desire to actually do that. And if you're making the dinner yourself, it's possible, but when you're attending someone else's, function, then it's difficult. But using what we said on far as the ADA or AADE site, that's about, offering substitutes and limits and portion control and that type of thing. Next slide. So I get asked a lot, so when we're talking about sweets and that type of thing, people think that aspartame is bad for them. And there's a lot of information out there that actually does say that. So you can kind of understand, but aspartame is the NutraSweet, it's the equals, but it actually is widely approved, and there are the agencies there from it, and that there's no reason to remove aspartame. There are things I tell patients, because when they read all this information, they're like, well, how are you right? And everything else out there is bad about it. There is, aspartame can increase the desire for more sweets. So really needing to stay on aspartame and not kind of flip-flop, because it can make you desire some additional cravings. There is some research out there about some weight gain with it, but I think the big thing is for diabetics is they have to realize that it is the option that's there for them when they want a substitute. Now, the better substitutes are the ones there on the top. So it's the stevias, the stevia, those type of sugar alcohols and stuff like that are the better ones and the more healthy. And I don't even know if I would say healthy. They have less high glycemic index. So in that respect, it's better than aspartame, and supposedly better weight loss on these drugs, or on these sugars, excuse me. But you do have to realize they're more expensive. And so in the patient population that we're using and treating, to buy a stevia box can be $5 to $7, and to buy sweetened low or NutraSweet or equal, it might be $2. So kind of every dollar counts sometimes. So better, yes. Have to, no. So if you ever get that out there as far as the aspartame, and they're like, well, that's bad for me, so I'm drinking regular soda, you really just have to change that mentality, because that's not the case for diabetics. So that's just some information for y'all. that's all I have for you. I was trying to keep it simple and sweet. And like I said, I think everyone just needs to utilize medical nutrition therapy. We have it here. It's on the 4th floor of our hospital. So if it's not in your local areas, you can try to get them up here. But questions?
That was awesome. Thank you so much. Yeah, does anybody have questions? Anything you'd like to ask or talk about?
Yeah, I actually have a question. So I know the ketogenic diet is very popular nowadays. So I was just wondering if that is particularly helpful for patients with diabetes, since it's a lower carb, higher protein diet.
Did you say keto diet? Because you cut out.
Yes, a keto diet. Were you able to hear the rest of the question as well, or?
I wasn't sure what the diet that you said.
Oh yeah, keto diet.
Keto diet. That's like the new fad, and that's so I don't personally, and I'm giving more, my personal experience, and 60-70% of my population of patients that I see are diabetics. So I don't discourage it, because honestly, most of our diabetics can't do a full keto diet. So I think anyone that truly does a true keto diet, that's unhealthy. But my patients can't do a full keto diet. So if they're even attempting to keep it that low carb, keto diet is low carb. And so I think in that respect, yes, it's healthy. So I always just say, sure, give it a whirl, allow yourself some modifications, I guess is the terminology I use, and that will get them lower carb if they try to do keto. So your patients that are very aspirational, then potentially I would say no. Type 1 diabetics also can't do all keto either. So no to type 1s. Type 2 aspirational, but I don't think I've found any of my patient population that has successfully done keto. I had one patient actually do keto and did the HCG shots, and she was down to a 500 calorie diet on HCG shots and keto, and she was hospitalized for about 4 days. Sick. So there are patients that absolutely could do that. So just, think about how well you know your patient. And most of my patients could never do full keto. So yes, I encourage it.
Thank you.
Mm-hmm.
Any other questions, any comments or cases that you guys had that you wanted to ask about today? All right. I do have this one case prepared. I think we have the time if you guys are okay to talk about it. I can't answer questions about it because it was submitted, and so I only have the information on it. Sure. But I think it's worth going through. Give me just 1 second. All right. So Mitra and I are going to take turns reading this, so please bear with us. All right. So it's a 48-year-old male, white with Medicare. You can see his height and weight here and kind of some of the labs. Has an A1C of 13.2 generally. Of course, these are some of the other things. HDL is 41, LDL 132, ALT 44, and AST 31. Excuse me. Take over.
Sure. Yeah, so some of his other labs you can see, like his glucose, 337, GFR was 80. And then, so some of the general endocrine questions that came about was basically the feedback on the approach. So, discuss any adherence or barriers, lifestyle, or whether to switch the insulin frequency or the dose. And a little bit more of the information that was received was the year of diagnosis was 2008. Years of insulin intake was unknown. There was no family history of diabetes or early CAD. Some of his symptoms were burning and numbing of the extremities. And you can see some of the other past medical history. So diabetic neuropathy, anxiety disorder, hyperlipidemia, hypertension, UTIs, and there were no known hospitalizations.
And this is what the insulin and medication regimen looks like that he's been on.
Do we have blood sugars?
Doesn't look like they do continuous glucose monitoring. Here, the glucose was 337 and the A1C was 13.2.
Go to meds again.
Yep.
Okay.
All right. So sorry for that brief and quick case presentation, but questions, comments?
Right. Do you want me to start to expound?
Certainly.
Okay.
And we'll take all kinds of feedback, everybody. Dr. Rexford, did you want to say something real quick?
I was just going to ask the hub people if you think the glipizide is really doing anything in this guy.
Not if he's been on it since 2008. No.
Okay.
Yeah.
Great.
So probably not. Glipizide is, risk of hypoglycemia if it is working in conjunction with insulin. So, and it looked like his GFR is fine. So, but 2008, there aren't too many of my patients that actually remain on any sulfonylurea after about 10 years of use. And actually, he's a young guy, so I can see why it's still on as well. But, as they get older, we get rid of that. So I probably would not continue it after that many years of use. 70-30 insulin is probably out of a cost issue. So we have to work with it a lot, not our first choice. So depending upon Medicare and what other supplements or Medicaid is underneath of it, Tresiba is really well received for Medicare and Medicaid. So sometimes we try to utilize that if it's the same cost. But with sugars of 330, some of it is how often does he eat as far as utilization of it, when is he administering it, just says AM and PM. But 70-30 is hard to get coverage through the nighttime because I had a patient on it and was having lows around 4 in the morning, 3 in the morning, and they were taking it about 9 to 10 p.m. at night. Well, when does the 30% start to peak? Just about that time when they're sleeping and not eating. Yeah. So remember, 70-30 should be prior to meals, and so if people are eating at 4 or 5 in the evening, that insulin gets hard to manage for those early people that eat early in the evening, 4 and 5 o'clock. I'm like, oh, because it won't last until the morning. So that can tend to pose as a problem. But an A1C of 13 needs a lot more insulin and trying to figure out what their dietary habits are in order to utilize 70-30. So increasing that. I don't know why this patient isn't on metformin. Sometimes you just kind of suspect they don't tolerate it, but he's kind of young, so I try to force metformin on most of my patients with good renal function. And I had a lady the other day that told me that she had, I think it was stomach cramping, and she hasn't been on it for like 5 years. So I'm like, oh, let's just try it again and see if you tolerate it. So he's a young guy. who knows what excuses that he had, but I'd probably try metformin again, depending on what they say. And then, yeah, extended release is a good option if you can try that. And then even if you can get to like 1,000 milligrams, I still try to leave patients on at least that much, even if you don't get them to the 2,000 daily dosing. And then your other drugs are even Medicare is covering Victoza. So potentially adding something like that in. His weight I didn't see a BMI, but he was like 280 pounds. So, adding something like that in to help curb the appetite and A1C. But saying that, Medicare, if your A1C is over 9, they're not going to allow us to start that. So you're going to probably start with a lot of insulin management, increasing that dose, try metformin, get rid of glipizide. I might even start Actos on him because he's a little bit younger. And males tend to do better with Actos. 30 milligrams to start with would be another good oral agent if they're combined with that. So trying to get at least 2 oral agents along with insulin would be a good idea. Don't like the cholesterol medicine. His LDL is 130. So always touching on cardiovascular risk factors. His LDL is I think I saw 132 or something like that. So somatostatin isn't a great drug, has a lot of interactions with other drugs. So going to moderate dose statins, which are your Lipitor, atorvastatin, or rovastatin, Crestor. So I tend to stick to those 2 drugs because ADA recommends moderate dose statin therapy for all diabetics. So you might as well use the ones that you can actually get to moderate dose therapy on. Urinary tract infections is going to limit you a little bit on using SGLT2s, which is your Invokana, Jardiance, and those also can be expensive. So you would definitely stay away from those for a little while until the A1C is lower, and you'd have to really investigate urinary tract infections. So you'd want to watch that drug classification since he says that. But 30, I try to also do 70-30 insulin as equal as possible, but you do have to consider diet. So a lot of times the second dose, because that's their larger meal, tends to be a little bit higher in dose because of the 30% of short-acting insulin in there. So I try to keep them close, but you need blood sugar readings, so we don't have any. And that's really going to dictate. So someone on 70-30 really needs to do blood sugars 4 times a day for you. So they're doing it prior to their meals and prior to bed. And prior to bed means not an hour after they snacked either.
Right.
That really changes things.
Do you guys have a recommendation? So you said 4 times a day for the continuous glucose monitoring. Recommendation on the device?
So it depends on cost, what they can afford. If this person isn't checking their blood sugars, Medicare and Medicaid will require 4 times a day blood sugar checks for 3 months before they're going to authorize use of the CGMs. So he's going to have to start with that no matter what, at least 4 times a day checks. And then once you see that, then potentially be able to go into some of those devices, which will help them. And insulin 3 times a day. See, I can, Shree's over here giving me the feel. So, again, without blood sugars, the patient's only doing it twice a day, but 70-30 can be 3 times a day. Sometimes we still do twice a day and maybe a little evening dose of regular or something, but without blood sugars, it's hard to figure out what you want to do because you can't do it safely.
Sure. Definitely. Thank you so much. Yeah.
I have a question. For a patient on the 70-30 insulin, okay, what would be the ideal way to manage their insulin adjustment? I mean, if I have the option of checking only 2 times blood sugar, so it would be just before meal and before lunch and before dinner to adjust the 70/30 insulin?
So they should do it before they're dosing their 70/30 insulin. So if they'll only do it twice a day for you, you definitely need the fasting in the morning. And that's when they should be dosing that 30 minutes prior to breakfast. And then their second dose should be later in the day, so prior to dinner would be the second dose when you're only twice a day dosing 70/30. And so if you're only twice a day checking, then those are the 2 times a day, but it needs to be 4 times a day.
Okay, thank you.
Mm-hmm.
Thank you. We also had a question that says, can you get around the requirement for 4 times a day testing by using one of the 2-week Libre Pros or something similar like that?
By the using the Libre.
Like the CGMs.
For Medicare and Medicaid,
Yeah.
no, they actually require, Medicaid requires written blood sugar logs 4 times a day, every single day for 90 days. And they have to pick up their meds every 30 days for 6 months. So Medicaid is really giving a lot of pushback on covering the Freestyle Libre or the Dexcom. So they truly have to be a very compliant patient before they'll allow us to utilize those.
Okay.
I'm sorry.
I was just curious though, I mean, if you really want to get some data to adjust him quickly, isn't that an option?
No.
Okay.
A freestyle or like a professional version may give you that option, but once again, those also have to be provided by insurances in order to charge for them.
Well, that's what I was asking. I mean, couldn't we do the 2-week Pro?
Oh, the professional
The
version.
professional one, yeah, and at least get some data to start to adjust his insulin a little bit more intelligently.
Yeah, we tried to utilize that. Those do have to be authorized for us to bill for them because they are $60 a pop to buy them. And unfortunately, our patients, yours may very well live a lot closer, but ours just don't want to come back to have that placed. So, but being a primary care doctor, your patients probably live a lot closer. So yeah, you very well could. And, if they're able to see, how they could feel better by getting their blood sugars under control may very well help them, but they can't actually see their blood sugars on those. They just virtually wear them and they don't have to do anything but wear them. So it can help you a little bit, yes, but in a long term.
And that won't count then towards their 2 weeks of monitoring their blood sugars, because that's just the requirement of Medicaid.
Yeah, but I'm just thinking, this guy's A1C is 13. We're talking about his A1C is 13 and his blood sugar is over 300. We can at least start something.
I would start with just fastings. I mean, I would start adjusting insulin just with a 1 time a day blood sugar. So yeah, absolutely. So you can go up about 10% on insulin about every couple of days, provided they're not dropping fast. But a 10% change of insulin is minute for someone that has an A1C of 13. So, someone that's taking 30 units in the morning, you could, I'd probably go up 6 or 8 units just with the morning insulin, with knowing that the A1C is 13. But moving forward, they at least have to give you some fasting sugars. But remember, the fasting sugars could be high because that insulin is going to wear off by the morning.
Yeah. Well, that's perfect. Thank you guys so much. They're really going to love those recommendations. And I really appreciate the people chiming in too. So we have about 15 minutes left. Does anybody else have any questions or cases that you guys want to bring up right now? Thank you so much again for the didactic. That was wonderful. And thank you guys for discussing the case. Let's see. What does our next session fall on? We will not be here in 2 weeks because that is the day before Thanksgiving. So I will let you guys know when in December we will be meeting. And it may very well be the only one meeting in December, because if this one falls in the 4th week, that one's going to fall in the 4th week. So that's probably how that's going to work out. So I will reconvene with everybody. And thank you all so much.
Thank you.
All right, thank you.
Bye, guys.